Recording in progress.
Good morning, everyone. Welcome to our conference entitled Tailoring Options for the Management of Breast Cancer. Um, I am Dr. Christine Polido Brillo from the Institute of Radiology and Allied Sciences. I will be the moderator for today's meeting. May we remind the following house rules for this conference. Kindly turn off your cameras and your microphones as well during the entire event, except for the open forum, wherein you can throw in your questions to our speakers. If you also have questions, you may also type in the chat box, and it will be addressed during the open forum at the end of the session. To start off, let us put ourselves in the presence of the Lord.
Heavenly Father, we come to you today with humble hearts, seeking your guidance and wisdom as we begin this program. Lord, we ask that you would bless every person who has gathered here today, and that you would be present with us in a special way. We pray that this program would be a time of learning, growth, and fellowship for all of us. Help us to listen to one another with open hearts and open minds, and to support one another as we strive to serve you in all that we do. Please give us the strength and the courage to follow your will and to use the gifts and talents you have given us to make a positive difference in the world. We pray all of this in your holy name. Amen.
To give our opening remarks, please welcome Dr. Jose Edsel Tamayo. He is the Deputy Medical Director for Professional Affairs of the University of Perpetual Help Delta Medical Center and also the head of the section of Pulmonary Medicine.
A post-Katrina sunny morning Saturday to everyone. And on behalf of the Perpetual Health Medical Center in Las Piñas, the Medical Director's Office under our Executive Medical Director, Dr. Adrian Kidlat, our Deputy Medical Director for Medical Education and Training, Dr. Virginia Crisostomo, and the head of our Hope Institute, Dr. Jinjin Ong Cornell. I would like to recognize the wholehearted efforts brought by the chair of our Tumor Board Committee and concurrently the training officer of the Department of Surgery, Dr. Jennifer Mercado, whose organizing committee has come up with timely and interesting topics for this multi-specialty forum entitled uh, Tailoring Options for the Management of Breast Cancer, graced by our distinguished resource speakers and attending delegates. As you may well know, October is Breast Cancer Awareness Month, a commemoration being celebrated since 1985, started by the American Cancer Society, with breast cancer or breast health in general being symbolized by the pink ribbon. Without much ado, I gladly welcome each and everyone to this continuing professional development learning activity. Let us optimize all the medical knowledge that we could gain from this important session. The healthcare workers to the general public. Once again, welcome and congratulations.
Thank you, Dr. Tamayo. So we'll begin with our first lecture. Our first speaker is Dr. Pauline Toledo Aycocho. She graduated medicine from the University of Santo Tomas and also finished residency at St. Luke's Medical Center. Also, her fellowship training as well in breast imaging. She is a fellow of the CT-MRI Society of the Philippines and of the Diagnostic Breast Imaging Society of the Philippines, as well as the Ultrasound Society of the Philippines and Philippine College of Radiology. Currently, she is affiliated at Asian Hospital Medical Center and of course Perpetual Health Medical Center, among others. Please help me welcome Dr. Pau Toledo Aycocho.
Good morning, everyone. I will be sharing my slides now. Good morning, everyone. I am Dr. Pau Toledo Aycocho, and my lecture for today is entitled Not Just Through Excision Biopsy, Breast Imaging and Image-Guided Biopsy for the Diagnosis of Early Breast Cancer. The objectives of this lecture are to review the commonly utilized breast imaging techniques, which include mammography and breast ultrasound. Then we discuss a little further the less commonly utilized modalities such as contrast-enhanced mammography and contrast-enhanced MRI. We will talk about the indications for each of the imaging modalities and discuss some of the common findings from each modality by looking at a few cases. Lastly,
but you said he was all right.
Yes, he's lost his left hand, so he's going to be all right.
You son of a bitch!
He's a very literal man. Yes, that's more the way I would take the news.
Oh, this guy again.
How is he, Doc? Looks like he's dead.
Oh my God!
Oh, little guy. The tears are coming.
I think
Just to be clear,
there's a problem with the audio, or you got muted.
he just looks like he's dead. He's got like blue paint on.
for a while.
He's going to be fine. What is wrong with you?
There, we could hear you. We could hear you already.
We will look into the different procedures that can be utilized in image-guided localization of breast lesions. The first part of this lecture is on breast imaging.
These are the breast imaging modalities available here in our institution. We will go through each of these in the following slides. It is worthwhile to note that the first four are not only the more commonly performed imaging modalities but are also anatomic or morphology based, whereas the latter two are physiologic or vascular based. Anatomic or morphology based breast imaging include digital mammography. Digital mammography remains to be the gold standard for breast cancer screening. Here in Perpetual, as in several other institutions throughout the country, DBT has been used primarily over digital mammography, both for our screening and diagnostic procedures. Digital breast tomosynthesis eliminates obscuration of findings by the overlapping fibroglandular tissues of the breasts, giving us additional information with minimal increase in the amount of radiation. This is a case of a 51-year-old female with screening detected suspicious microcalcifications. These show no definite sonographic correlate and turns out to be TCIS. This next case is also a screening detected TCIS, this time presenting as architectural distortion, which is actually not evident in the digital mammography but was detected in the tomosynthesis images. Initial sonography also missed this lesion, but second look ultrasound detected a corresponding irregular hypoechoic mass. The diagnosis of ductal carcinoma in situ has increased largely due to the increased performance of screening mammography. Approximately 80% of DCIS will present as calcifications on mammogram, and the most common ultrasound finding is a hypoechoic irregular hypervascular mass. Digital breast tomosynthesis, as we have seen in the previous case, offers better lesion localization, which results in increased cancer detection and decreased recall rates. It is also able to localize tomosynthesis-only lesions and identify vascular structures for better image-guided lesion localization and planning. We now go to the other popular breast imaging technique, which is breast ultrasound. We have both the handheld and whole or 3D breast ultrasound here in our hospital. Majority of the breast ultrasound examinations performed in the Women's Center are diagnostic, but for this lecture, I would like to emphasize the role of ultrasound as a supplemental breast cancer screening tool. Multiple studies have already confirmed the incremental cancer detection rate capabilities of whole breast ultrasound. However, its use carries an increase in false positive findings, high rate of short-term follow-up, and lower positive predictive value for biopsy when compared to digital mammography and MRI. In this journal entitled Comparison of Cancers Detected by Screening Breast Ultrasound and DBT, they noted an incremental cancer detection rate of 3D breast ultrasound to be 2.4 per 1,000 versus that of DBT, which is 0.4 per 1,000, both when added to digital mammography. Also, when compared to DBT, which detects in situ lesions, they found that lesions detected on breast ultrasound are actually invasive. Morphology-based imaging have long been the go-to imaging modalities for the breast. The high-quality mammography images, as well as the readily available and low-cost breast ultrasound examinations, are usually sufficient for us radiologists to answer the clinician's clinical question. However, the significant number of patients with dense breast tissues, which may mask underlying pathologies in mammogram, the operator dependence of breast ultrasound, and the ceaseless drive to detect breast cancer as early as possible somehow pave the way for vascular-based imaging. After all, we do contrast studies for all the other cancers, so why not do it for breast, right? Next are the physiologic or vascular-based breast imaging. These include CEM and contrast-enhanced MRI. These studies basically exploit tumor angiogenesis, which as we all know recruits blood vessels that are more permeable to contrast, thus being able to depict neovascularity, sometimes even before a discrete mass can be detected. Let us first discuss contrast-enhanced mammography, which uses dual energy acquisition using low and high energy X-ray spectra following IV contrast injection. The images produced gives us both anatomic and functional information, since the low energy images that it produces are actually comparable to that of digital mammography. The indications for contrast-enhanced mammography are the following: to determine the extent of disease in newly diagnosed breast cancer, to assess response to neoadjuvant chemotherapy, as a problem-solving tool for lesions which are indeterminate on digital mammography, breast ultrasound, or even clinically. It is also used for screening women with intermediate to high risk of developing breast cancer. And lastly, as an alternative to MRI when patient has contraindications. For the purpose of this lecture, I would like to discuss the role of CEM in breast cancer screening. As I have mentioned earlier, digital mammography remains to be the gold standard for breast cancer screening, with breast ultrasound being the most common supplemental study. As for CEM, it is superior to digital mammography with or without breast ultrasound, particularly in patients with dense breasts. It has high sensitivity which approaches that of MRI, but is less specific than MRI. It has an incremental cancer detection rate of 13.1 per 1,000 women, and studies found no benefit in performing breast ultrasound if your CEM is negative. The National Comprehensive Cancer Network Breast Cancer Screening Guideline version 1 2023 included CEM as an alternative for high-risk women who has contraindications to doing MRI. Now, my discussion of MRI will be limited to its role as a vascular-based imaging. So I'll not be discussing further plain MRI studies which are actually done solely for the purpose of implant evaluation. Currently, breast MRI is the most sensitive test available for detecting breast cancer, with a cancer detection rate of up to 18 per 1,000. The following are the indications for a contrast-enhanced MRI. I will be discussing further the first two items in this list. Let us look at this case of a 39-year-old female who came in due to a palpable left breast lump. I do not have the breast ultrasound images, but focus scanning of the clinically palpable lump showed an irregular hypoechoic lesion, which has a maximum diameter of 3.2 centimeters. Mammogram shows focal asymmetry in the upper outer quadrant of the left breast, which is also where the palpable lesion is. Just a disclaimer, these images were not taken here in our hospital. This is not actually a full-field digital mammography study, but a CR study. As you can see, the large size of the breasts precluded adequate imaging, which resulted in portions of the breast being cut off from view. It was a good thing that the patient opted to do an MRI, which actually revealed a larger lesion seen as a segmental non-mass enhancement in the outer aspect of the left breast, having a widest dimension of more than 7 centimeters. That is double the size of the lesion measured on ultrasound. It also shows us the presence of pathologic level 2 axillary lymph nodes here in the sagittal view. Involvement of the underlying fascia and muscle are ruled out. The nipple and the skin are not involved. There are also no abnormalities seen in the right breast. The patient's left breast lesion turned out to be invasive ductal carcinoma with mucinous feature nuclear grade 2. With all this added information, the routine use of MRI in the preoperative setting and in determining surgical outcomes remains controversial. For now, breast MRI has the highest diagnostic accuracy for the detection and staging of breast cancer. It is the most sensitive modality currently available for identifying DCIS, particularly the high and intermediate grades, and is more accurate than mammography in evaluating the extent of DCIS. And lastly, DCIS depicted with MRI has a higher likelihood to progress to invasive cancer than does DCIS depicted with mammography. Moving on to another indication of breast MRI, which is in patients with pre-silicone injections. These are mammograms and breast ultrasound images of a patient showing pre-silicone injections in both breasts. These obscure the breast parenchyma and renders both imaging modalities suboptimal for interpretation.
Now look at these MRI images of the breasts from an actual patient. Axial T1 weighted and sagittal T2 weighted images show circumscribed oval foci scattered in both breasts. A silicone-only or water-only sequence will allow us to identify pre-silicone and differentiate it from other lesions with similar signals such as cysts. Finally, in the post-contrast images, all of these lesions as well as the remaining breast parenchyma are clearly shown to show no enhancement. Remember, for your patients who have injectable breast implants, the imaging modality of choice is MRI. Lastly, I want to share these two specific indications to do MRI. First is for patients with pathologic nipple discharge with no abnormality on digital mammography or breast ultrasound. So aside from ductography or microdacectomy, as per the ACR practice parameter, MRI can also be helpful for these cases. Next is a finding of subtle or questionable architectural distortion on DBT with no definite sonographic correlate. Now that we are seeing more tomosynthesis studies, we are also starting to see these kinds of findings. And in this study by Samrin et al., these findings can be further evaluated with MRI. And if no definite MRI correlate is present, short interval follow-up can be opted. Here are some differences between contrast-enhanced mammography and MRI. CAM is a shorter procedure and most patients find CAM more comfortable as the positioning is similar to that of standard mammography versus the prone positioning in MRI. MRI is also a longer procedure taking usually more than 45 minutes compared to 10 minutes of CEM. The drawbacks of CEM though are allergic reactions and slightly increased radiation dose compared to digital mammography. But still, it remains below the regulatory dose limit according to the MPSA. Two advantages of MRI over CEM is its ability to provide both 3D and kinetic information. The lack of kinetic curve in CEM though can be compensated by performing delayed images, which improves sensitivity from 80 to 90%. Lastly, MRI, as it is a cross-sectional study, offers good visualization of the posterior breast, chest wall, and axilla compared to CEM. The last part of this lecture will be on image-guided breast biopsy. Guidance for biopsies and lesion localization can be done using either breast ultrasound, digital mammography, digital breast tomosynthesis, stereotactic techniques, and MRI. Non-wire localization and MRI-guided procedures are currently not available here in the Philippines. Percutaneous biopsies using fine needle and core needles have long been used primarily for histologic assessment of non-palpable breast lesions. Today, this practice has shifted to include all breast lesions, including those that are clinically palpable. The use of core over fine needles has also become standard, with the goal of obtaining adequate tissue samples not only for diagnosis, but also to allow for immunohistochemical tests to be performed. Image-guided procedures will also aid to avoid complications. This image is a SCOUT tomosynthesis image taken before stereotactic vacuum-assisted biopsy. Being able to scroll through the images allowed me to better identify the proximity of my target to the adjacent vascular structures. We actually did reposition this patient once to move the vessels away from the biopsy site. Another use of imaging is in preoperative VAR localization. Today, with more surgeons doing breast conservation surgery, the purpose of VAR localization has slightly shifted from just tissue sampling for diagnosis to that of being part of the surgical planning. The approach is to review all the available imaging studies to determine which modality best approximates disease extent. The initial imaging modality of choice will be ultrasound, since it is less time-consuming, more comfortable for the patient, and there is no radiation. Wire placement can also be seen in real time when using ultrasound. For microcalcifications and architectural distortions, digital mammography is used to guide wire placement if there is no sonographic correlate, or if the full extent of the lesion cannot be delineated on ultrasound. Bracketing, or the use of two or more wires, is generally used when the disease extent is 2 to 3 centimeters or greater. But sometimes, this can be modified by placing a single wire and placing skin markings and margins to guide the surgeon's excision instead of placing multiple wires. In the end, communication with the surgeon is paramount to a successful pre-procedural lesion localization. Now, aside from pre-surgical planning, image-guided vacuum-assisted excision is definitive management for breast pathologies are also gaining popularity. In this journal from the Brazilian College of Radiology and Diagnostic Imaging published last May 2023, they noted the evolution of vacuum-assisted procedures, which was introduced in 1995 using gauge 14 needles to do diagnostic biopsies. Presently, needles up to gauge 8 are being used for vacuum-assisted excision, focusing on removing the entire lesion. When doing our planning for vacuum-assisted excision, the following should be considered. Number 1 is the location and size of the lesion, its relationship or proximity to other structures, and lastly, patient comfort. It is also worthwhile to note that pathologists will not be able to comment on the completion of the excision and its margins from specimen fragments submitted. The specimen completion will depend in the post-biopsy scans as well as the post-biopsy clinical assessment and physical examination. In some clinical practice, they would send out 2 separate sets of specimen, one containing the lesion and one including the margins removed 360 degrees around the lesion. Indications for doing vacuum-assisted excision are the following. One is to excise spiral sleeve lesions. The previously mentioned journal suggested its use in the following high-risk lesions. It may also be used in excision of benign lesions as requested by the clinician or the patient. It is also used to do repeat biopsy when there is radiologic pathologic discordance. In some clinical settings, vacuum-assisted excision is also being used in treating mild gynecomastia. There are 2 trials pertaining to uses of VAE. The Responder trial tried to investigate the use of VAE in the diagnosis of a complete pathologic response. However, the accuracy of imaging evaluation after neoadjuvant chemotherapy is limited, so there have been uncertainties as to whether the region of the tumor with PCR has been sampled or if unrepresentative tissues were removed. This trial has now been discontinued. Next is the SMALL trial, which is currently ongoing and in phase 3. This trial investigates the use of vacuum-assisted excision as definitive management for patients with screening-detected small biologically favorable cancers. As with any other procedures, here are some complications of VAE, which includes ecchymosis, infection, pseudoaneurysm formation, pneumothorax, hematoma, and skin laceration. That was my last slide. These are just some take-home points. Number 1, mammography remains to be the gold standard for breast cancer screening. For patients with injectable implants, contrast-enhanced MRI is indicated. Contrast-enhanced mammography and contrast-enhanced MRI, being both vascular-based imaging, have common indications. Considering the pros and cons of each modality shall help us decide which study is best fitted for our patients. And lastly, for an effective image-guided procedure, making all the imaging modalities available and communication between the radiologist and the surgeon are important to ensure that the most appropriate modality is used and the purpose, whether it be diagnostic or definitive, is fulfilled. These are my references. Thank you for your kind attention.
Thank you, Dr. Rapal, for that lecture and emphasizing that the diagnosis of breast cancer is not just through excision biopsy. For our next lecture, we have Dr. Jennifer Ann Mercado. She is the current head of the tumor board here in this institution, as well as the training officer of surgery. She graduated from the University of Santo Tomas, and had her general surgery residency in UPPGH. She had her surgical oncology fellowship in St. Luke's Medical Center, and her surgical oncology observership in Memorial Sloan Kettering, New York. She is a fellow of the Philippine College of Surgeons, Philippine Breast Cancer Society, Philippine Society of General Surgery, Society of Surgical Oncology of the Philippines. She is an active consultant here in Perpetual Health Medical Center Las Piñas, NKTI, St. Luke's Global, and Quezon City, among others. Let us all welcome Dr. Jen Mercado.
Thank you for your kind introduction. Today I am tasked to speak about the different surgical options, both for the primary tumor and the axilla. Next slide, please. These are my objectives. Next slide. And I have no conflict of interest to disclose. Next slide, please. So we have gone a long way from the time that Halsted has recommended the removal of the entire breast tissue, including the pectoralis major. Next slide. The direction in breast cancer surgery is towards de-escalation, as we see from the 1970s up to the present that both for the surgery of the primary tumor and of the axilla, we try to do less and less surgery. Next slide, please. Next slide, please. So the landmark trials of NSABP06 and Milan study has shown that there's no difference in the overall survival or the DFS when you're comparing breast conserving surgery versus mastectomy. Later studies would also show better breast cancer specific survival, even if you adjust for several factors. Next slide. Presently, we also see the emergence of the surgical technique of oncoplasty. So this came from the words onco, meaning tumor, and plastic, meaning to mold, as it aims to bring together oncologic safety with negative margins with good cosmesis. We still have our friends from plastic surgery doing the major reconstructions after mastectomy, such as implant insertions and cram flaps, but oncoplasty would usually be done by the surgeon with the reconstruction done immediately after the surgery. So this started in the 1980s in the United Kingdom, and the term was coined by Dr. Ostrich in 1993, and this has spread rapidly from Europe to US. Next slide, please. Next slide, please. So when we decide whether a patient is a good candidate for oncoplasty, we consider different factors such as tumor characteristics, favoring tumors which are localized in quadrants difficult to do resection for without deformity, breast-related factors such as size, density, stage of ptosis, and status of the areola and quality of skin, and patient characteristics as well. Next, please. Next slide. So, oncoplasty is indicated for tumors with an excision volume of more than 20%. So, if you need to remove more than 20% of the breast volume, or the patient has very large breast, removing the tumor in one side would lead to deformity. Partial response after neoadjuvant chemo, multifocal tumor, and tumor localized in difficult quadrants such as the upper and lower inner quadrants. Contraindications, on the other hand, include margins needing mastectomy, persistently positive margins, inadequate breast volume, severe microcalcifications throughout the breast, eccentricity, and contraindications to radiation that would come after. Next slide. So, oncoplastic surgery is usually divided into volume displacement and volume replacement techniques. So, in volume displacement, you have level 1 and 2 depending on the volume of tumor of the volume of the breast that you will remove, and volume replacement or level 3 when you need to remove more than 50% of the breast tissue. Next slide, please. Besides tumor, breast, and patient characteristics, we also to consider the location of the breast tumor when deciding what incision and what technique to use. Next slide. So although there is paucity of randomized controlled trials, there is a lot of retrospective and prospective cohort studies showing that when you compare breast conserving surgery versus oncoplastic breast conserving surgery and mastectomy, you would see that there is no difference in local recurrence, DFS, and overall survival. Next slide. If you compare mastectomy, breast conserving surgery, and oncoplastic breast conserving surgery after neoadjuvant chemotherapy, you would also see that there is no difference in local recurrence, DFS, and overall survival. Next slide, please. Again, comparing BCS and oncoplasty, you would also note that there is little or even lower risk of positive margin and a lower re-excision rate. Next slide. The chance of converting to mastectomy is also low as compared to BCS, and there is even a chance to do extreme oncoplasty when you have to remove more than 50%, and you can do this with extended indication for T3 lesions, multifocal and multicentric lesions, post-neoadjuvant, and with patients with extensive DCIS. However, in such cases, there is a need for symmetrization technique for the contralateral breast. Next slide. Comparing complications, there is no significant difference. However, the complication rate would inadvertently be increased the higher the level of reconstruction you do. That is why it is always best to go simple, do the simplest technique so that you will not have complications that may possibly delay the adjuvant radiation that will come after. Next slide. These are some cases that we have done comparing the immediate post-op and after radiation has 1 year after radiation. So this is a patient with post-bilateral batwing excision. Next slide. This patient, if you look closely, you will see the incision on the left lateral. This is a post-lateral mastectomy. Next slide. And this is a patient also with the post-lateral mastectomy taken several times before, right after, and 1 year after the surgery. So we have been doing oncoplastic surgery in perpetual las piñas for several years already, and we are currently gathering our data to look at the complication rates and possibly in the future to look at the local recurrence rates in our institution. Next slide. So it is non-inferior to BCS and mastectomy as seen by non-RCT studies. That is why there is a need for studies with better designs. And as we start this practice, we have to do data gathering for quality control. We have to train our residents and standardize the technique. We have to do good patient selection and always minimize complications as well as work within the MDT. Next slide. Besides breast conserving surgery, nipple sparing mastectomy and skin sparing mastectomy is also being practiced, which entails removal of the entire breast tissue with preservation of either your nipple areolar region or your periareolar skin. The indication is usually when you when you do mastectomy and with immediate reconstruction, either by silicone implant insertion or more complicated reconstruction such as the tram flap. So patients with an early breast cancer more than 2 centimeter from the nipple can have their nipple areola area spared. This can also be done for patients with DCIS as well as for prophylactic bilateral mastectomy for patients with BRCA gene mutation. Compared to the traditional mastectomy, this leads to better aesthetic result and comparable outcome and recurrence rate. Next slide. Patay. Patay. Sorry, nawala ako for a while. So the problem with nipple sparing mastectomy and skin sparing mastectomy is that there is decreased visualization as you try to make very small incisions. Hence the birth of robotic surgery to include breast cancer surgery. The advantages of this would include ergonomic advantage for the surgeon as he maintains good visualization even if the incision is small, to decrease the numbness in the nipple area, which is usually attributed to the manual retraction being done in the open breast cancer, open nipple sparing mastectomy, and to lead to better aesthetic result. As you can imagine, the concerns here would include the high cost, the availability of the robot, and the question of are we doing thicker skin flaps and are we compromising oncologic safety? Now, there is an ongoing multicenter randomized controlled trial trying to address these issues. The results of which are being awaited. Next, please. So how about contralateral prophylactic mastectomy? So many studies have already proven that there is no benefit for cancer patients to have the other breast removed in patients who have low risk to develop contralateral breast cancer. This may be indicated if the patient would want to have symmetry as they will have silicone implant inserted or with tram flap, so that after a few years when the contralateral breast has sagged, to prevent asymmetry when the contralateral breast has sagged. This is also a good this is also good for patients with BRCA mutation carriers. Next slide. So there are many options. You just have to inform your patients of all their options as well as the pros and cons of each option. And then you have to give the patient time to decide. You can initially explain to them, meet them again, and try to ask them the questions that will help them to decide. And later on, when you meet them for the third time, try to get their final decision. Of course, it will be important for you to know the basics of these techniques so that you can guide them appropriately. It is also important to work with your MDT as to several aspects such as how do you deal with the breast surgery after neoadjuvant chemotherapy has decreased the size, and also we do our best to educate also our trainees that even if a breast tumor is operable, if the tumor is triple negative and HER2 positive with a tumor size of more than 2 cm and node positive, that we will not do surgery immediately. Next slide. Now for the axilla, next slide. So the axillary status is important before you do surgery or chemotherapy. And there is a very high false negative rate, both in physical examination and on imaging. When the ultrasound-guided biopsy of the lymph node is done, the accuracy depends on the size of the node. Next slide. Axillary node dissection or formal dissection would include removal of all axillary fat from levels 1 and 2 or if you have grossly positive level 2 up to level 3 in clinically node-positive patients. The indication for ALND in the age of neoadjuvant chemotherapy would include those with early luminal A breast cancer patients with a tumor size that is small but clinically node-positive, and those who maintain their node positivity based on imaging after neoadjuvant chemotherapy. Also, if sentinel node biopsy done after neoadjuvant turns out to be positive, the complications are multiple. You would have numbness, decrease in arm mobility, and a very high chance of lymphedema, which the incidence of which depends on many factors. Next slide. Hence, the gold standard of axillary surgery for patients with negative nodes would be sentinel node dissection. This would mean removal of identified axillary nodes most likely to drain the breast. The indications are the following: node negative patients in upfront surgery, node negative patients after neoadjuvant chemotherapy based on imaging, DCIS undergoing mastectomy or lumpectomy in areas such as the central breast or the axillary tail. Contraindications include the following. Next slide. So there are many dyes that you can use. You can use the blue dye and look for the blue node. You can use the ICG and use the appropriate scope or camera to look for the green and highlighting nodes. You can use the radioactive colloid and use the gamma probe to look for the radioactive signal. So we also try to remove palpable nodes. During frozen section, because of the ACOSOC Z11 and Amaroth, both for patients who are undergoing BCS or mastectomy, if the sentinel nodes removed has no positive nodes or up to 2 positive sentinel nodes, you can omit full dissection. On the other hand, if you have a positive 3 or more sentinel nodes, then you will have to undergo ALND or formal dissection. If the patient is post-neoadjuvant, the criteria for proceeding to ALND is different. If you have at least one positive macroscopic or even a microscopic focus of tumor on the node, then you proceed with ALND. The acceptable false negative rate in doing this is 5%, and the learning curve after which you are said to have done enough to be accurate is at 40. Next slide, please. So after neoadjuvant chemotherapy, the chance that both the primary tumor and the axillary nodes have the tumor has been removed in both areas ranges from 20% in luminal A to up to 75% in HER2 enhanced and triple negative patients. So the role of axillary surgery in these patients include the following. For patients who are clinically negative before the chemotherapy and after as well, you do sentinel node biopsy. If the patient has clinically node positive before and maintains to be positive upon imaging after, then you do ALND. And as mentioned, if it's positive converting to negative, you do sentinel node biopsy, and indications for proceeding to ALND has been discussed. However, you have to note that there is no long-term evidence of benefit for no axillary surgery in this subgroup. Next, please. Also, as noted by the ACOSOC Z1071 trial, the false negative rate here is 12.6%, which is much higher than the acceptable 5%. The following techniques can decrease the false negative rate. Getting more than 2 nodes, so the minimum is 3, using dual technique, so either blue dye and radioactive or ICG and blue dye, and removing the clip node. Next slide, please. So talking about the clip node, something new about the axillary surgery is targeted axillary dissection, wherein you place a clip on a biopsy-proven axillary node. So you do either FNAB or core needle on the axillary node. When you have in the same time that you do core needle for the breast tumor, then you put a clip on that identified positive node. Then you do chemotherapy, and after that, before surgery, the same node is being marked. 1 to 5 days before the surgery, you can put in a radioactive seed, or a few hours before, you can put in a wire hook to identify that clip node. And you remove that targeted node and the sentinel nodes as identified by another dye during the surgery. Next slide. So this is the technique. Note the clip placed on the initial biopsy and the radioactive seed as marked, and you remove it using the gamma probe if you put in the radioactive seed, or the wire hook through image guided biopsy. If either of the targeted node or the sentinel node turns out to be positive, then you proceed to ALNB. Next slide. So these are the indications for targeted axillary surgery. If you want to do imaging detected nodes or after neoadjuvant chemotherapy as discussed, this is said to decrease the FNR rate from 12% to 2%. Next, please. So the question is, can we omit axillary surgery if you are clinically node negative after neoadjuvant therapy? The ongoing trials are the following. Next slide. Can we repeat sentinel node if there is a recurrence after you have done BCS and SLND and the current recurrence is still node negative? So this is said to be successful in almost 73% of patients with a high specificity. And so in the NCCN guidelines, the recommendation would be to proceed with ALND if you fail to map the sentinel node in this scenario. Next slide. Next slide, please. Okay, so this table summarizes the indications for sentinel node biopsy, targeted axillary dissection, and axillary lymphadenectomy. Next slide. Also new are the options to decrease or address lymphedema. So one is axillary reverse mapping, wherein you use two dyes. One of the dye is injected in the upper arm to identify lymphatics that drain the arm. And then another dye will be used to isolate the axillary nodes, the sentinel nodes. And then you try to avoid removing the nodes identified by the first dye, but if that node identified by the first dye to drain the arm is also seen in the second dye, then you have to remove it. And afterwards, you reanastomose the lymphatics to the vein, to do a vein. Next slide, please. So this lymphovenous anastomosis is usually done by microvascular surgeons. Now, so after you do the ARM and you have to transect the lymphatics, you can anastomosis to the to a vein either by end-to-end anastomosis or by dunking technique. So this significantly decreases breast cancer-related lymphedema to 9.5% versus the usual 32%. However, we are still awaiting long-term follow-up results of this. This is currently a new technique that they have started both in the US and in Europe. Next slide. Can we omit axillary surgery altogether? So this randomized clinical trial, the SOUND trial, has 1,465 patients with clinically T1 image negative, clinically T1 but image negative nodes, and they compare patients who would undergo sentinel node biopsy versus those who will have no axillary surgery. These are the subgroup of patients that they would include, and the results showed non-inferior DDFS, but we are still to await the long-term follow-up. Next slide. So the obstacles in omitting axillary surgery completely are the following. First, sentinel node biopsy has proven itself to be a low-risk procedure. Secondly, if you do not do anything to stage the axilla, then you would have lost pathologic staging information that is important both in clinical trials for systemic and RT and RT techniques, as well as you have lost the information that would possibly give the patient a chance to receive additional treatments such as abemaciclib for hormone-positive patients with high-risk luminal A disease, capecitabine for triple-negative, and TDM1 for HER2-positive with residual lymph nodes. We would have to find a balance between the escalation of local treatment and the seemingly escalation of systemic treatment being seen. Next slide. So as a summary, the movement of breast cancer surgeries towards the escalation. Surgical options for the primary tumor include mastectomy, both your traditional open, nipple sparing, skin sparing, BCS plus or minus oncoplasty, as well as robotic mastectomy. Options will have to be explained to the patient, and the decision depends on the patient characteristics, tumor, breast characteristics, as well as the patient's desires and values. Again, you have to work within your MDT. Next slide. The axillary status is vital in the staging and treatment. Surgical options would include ALND for those with early luminal breast cancer and SLND positive for and with those with more than 2 positive sentinel nodes, and after neoadjuvant chemotherapy, persistently positive nodes clinically or sentinel node positive. However, the gold standard for node negative and those converting to node negative after neoadjuvant is sentinel node biopsy. There's an emerging option to decrease the incidence of and to treat lymphedema, and axillary surgery and radiotherapy can be omitted for elderly patients. I think one slide was lost. Next slide, please. Next slide, please. That is my last slide. Thank you.
Thank you, Dr. Jen, for that in-depth discussion on surgical options, especially emphasizing on de-escalation and breast conservation. Thank you, Dr. Jen. Our next lecturer is well known to all, Dr. Chito Cruz. Dr. Chito Cruz will give us a lecture on molecular profiling and how these influences management. Dr. Luis Cruz, or Dr. Chito Cruz, is a fellow of the Philippine Society of Pathology, Philippine Society of Oncology. He is also the section chief of the anatomic pathology here in this institution. And he is an active consultant also at the Los Santos Medical Center and New Sinai Hospital, Global Medical Center in Cabuyao, Laguna. Please welcome Dr. Chito Cruz.
Oh, dyan na. Ito lang. Okay. Good morning. Can you hear me?
Yes, Doc, we could hear you
Okay.
po.
I was tasked to lecture on molecular profiling and how it influences management. In the past decade, the field of oncology has witnessed substantial changes in the way patients with cancer are managed. With departure from one-size-fits-all approach and increasing focus on precision medicine based on genomic variants. Cancer precision medicine is defined as the use of therapeutics that are expected to confer benefit to a subset of patients whose cancer displays specific molecular or cellular features, most commonly genomic changes and changes in the gene or protein expression patterns in the genomic milieu. I will be presenting the current trends in breast cancer diagnosis and how it impacts management and therapy of breast cancer at the present time. Okay, so molecular profiling. By definition, molecular profiling is a laboratory method that uses a sample of tissue blood, or other body fluid to check for certain genes, proteins, or other molecules that may be a sign of a disease or condition. The condition can be a cancer. Molecular profiling of tumor DNA identifies alterations in genes and guides treatment that targets the specific makeup of the individual tumor. So, what does immunohistochemistry or molecular profiling intends to do? So, it will identify proteins that are present in cancer cells but not in normal cells, or that are more abundant in cancer cells, especially if they are known to be involved in cell growth, survival, or there are mutant or altered proteins that drive cancer progression. It also aims to identify abnormalities in chromosomes that are present in cancer cells but not in normal cells, which in some instances create a fusion gene, whose product, called a fusion protein, may drive cancer development. Okay. Morphological diagnosis, as what was discussed by the previous lecturers, are no longer the sole analysis requested to pathologists. So there are novel clinical demands that require the evaluation of prognostic and predictive factors for targeted molecular therapies through genomic and antigenic testing. We are in an era of targeted therapy, or what is called personalized medicine or precision medicine. So targeted cancer therapies are drugs or other substances that block the growth and spread of cancer cells by interfering with specific molecules or molecular targets that are involved in the growth, progression, and spread of cancer. So this is a table which is actually approved drugs for specific biomarker matching. So, as stated there, the Food and Drug Administration as well as this institution approved biomarker matching targeted drugs and routine molecular pathology testing for breast cancer. So you test for a specific gene or protein. In our case, the routine studies being done now are your estrogen, progesterone receptor assays, as well as your HER2. Upcoming and being used now is also, in addition to these three routine methods, is a proliferative marker exemplified by your Ki-67. BRCA gene mutation examinations are reserved for special cases wherein the chances wherein the patient has a strong family history and BRCA mutation determination is being done in this case. Next slide. Okay, molecular profiling. Although this is a mechanized or an automated procedure, the handling of tissues in these cases impacts the integrity of morphologic or the histologic as well as the molecular, yung genomic and proteinomic structure of the tissues being handled. So, tissue handling will greatly affect immunoreactivity, and as clinicians in laboratory as well as operation room personnel has this distinct responsibility to follow certain rules to preserve the integrity of the tissue while in transit. So you have to have the concept of ischemia time. You have to use the right fixative. You have to determine the duration of fixation as well as determine processing of tissue in the histopathology time. So in this slide, in ischemia time is the time interval from operation and proper fixation of the tissue. It is divided into two phases: your warm ischemic time, which is the time of anesthesia administration, ligation of vessels, and specimen removal from the patient. That's the warm ischemic time. This should be identified and logged into the tissue request so that there is a point of reference or time reference for reporting if the time elapsed is amenable to further examinations. The cold ischemic time is the time interval between tissue removal from the patient and arrival into the pathology lab. So the time interval being request or being followed now is within 15 minutes the tissue should be adequately fixed in a proper fixative. The adequate or the fixative being used is 10% neutral buffered formalin, and the regular formalin that we use sometimes in the operating room is not optimal for molecular studies. So molecular pathology has therefore become fundamental not only to inform on tumor diagnosis and prognosis, but also to drive therapeutic decisions in daily practice. Yeah. Okay, so Dr. Mercado has mentioned mga luminal types ng breast cancer. Ano? So we have when using molecular profiles, we can classify or subtype our breast cancers into the following. So as the table states there, once you do the routine immunohistochemistry examinations, you can subtype your breast cancers into either luminal A or luminal B, or what we call your triple negative breast cancer, in what they sometimes call as a normal like subtype of breast cancer, depending on the immunohistochemistry status. As the table implies, the ER positive, HER2 no negative, and Ki67 low immunohistochemistry subtypes of breast cancer are classified as luminal A. And luminal B are those breast cancers with ER positive, PR positive, HER2 new negative, but with a Ki67 high index. Or you have a ER positive, PR positive, HER2 positive with any Ki67. So if we're going to grade this, the luminal A will fall either into a grade 1 or grade 2 with good prognosis, and this is the most common type, your luminal A subtype of breast cancer. The luminal B has an intermediate prognosis and occurs in about 20% of breast cancer cases. Your HER2 overexpression subtype will display an ER PR negative with a positive HER2 and any Ki67 level. So this will be graded as a grade 2 or grade 3. In prognostication wise, this is qualified as or subclassified as a poor prognosis. This occurs in about 12 to 21% of breast cancer patients. Now we have what we call your triple negative cancer patients. So all the three routine histochemistry examinations are all negative, but this will require to really be subtype as a basal type of breast cancer if you do basal markers. So the basal markers are either doing your cytokeratin 5/6 or doing an EGFR. The basal type or the triple negative breast cancer patients are graded as 3. which also has a poor prognosis, and this occurs in about 11 to 23% of cases. What are the characteristics? Why do we profile or why do we subclassify these types of breast cancer? No? So there are certain characteristics of these luminal subtypes of breast cancer. No? So incidence-wise, as was stated, the luminal A is more common. Your ER-related genes are very high in luminal A subtypes of breast cancer and relatively low in luminal B breast cancers. Your HER2-related genes are low in luminal A and variable in luminal B. Your TP mutation, some institutions will also require your P53 mutation studies. Ano? So, your luminal A has a 12% chance of it having a P53 mutation, while the luminal B has a high incidence of 29%. Your proliferation-related genes, as exemplified by your Ki67, are relatively low and high in luminal B. Low in A and high in luminal B. So what does this imply? So this will give a prognostic significance for the characteristic luminal subtypes of breast cancer. Ano? So prognostication-wise, your luminal A breast cancers has a good prognosis, while your luminal B subtypes have a poor prognosis. Now, if you're planning to do endocrine therapy, the luminal A subtypes of breast cancer are very sensitive or highly sensitive to endocrine therapy, but the luminal B are less sensitive. Now, if you're short of doing the targeted therapy and opt to go to the previous cytotoxic therapy, the luminal A breast cancers, luminal A breast cancer types are less sensitive. Well, they are both less sensitive with this type of therapy. So molecular profiling also can be used to predict risk for metastasis. Ano? Although this has been long proven to be, the staging procedure has long been proven to be a good risk determinator for the chances of a breast cancer to metastasize. Ano? So this will depend on your tumor diameter, your histologic grade, your axillary node, presence of axillary node involvement or axillary node metastasis. And then, in addition to the staging procedures being done, you do also your hormonal receptor assays exemplified by estrogen and progesterone, as well as your HER2 status, as well as your Ki proliferation index. So patients with hormone receptor positive early stage breast cancer are at risk of recurrence up to 20 years after diagnosis. So extended endocrine therapy has been shown to improve disease-free survival. So how do we determine this? We use the subtype classification by molecular profiling. Now, there are newer methodologies because of to determine or risk metastasis. Aside from your routine immunohistochemistry examinations, you can use microarrays as well as addition of several other gene mutations present. So there are two current methodologies being used in some institutions. You have your Oncotype DX as well as your MammaPrint. So for tissue samples, your Oncotype DX can use your regular formalin-fixed paraffin sections, your paraffin blocks. Your MammaPrint can also make use of your formalin-fixed, but it's better to have fresh or frozen samples. So what does this do? You have several genes that are being tested. For Oncotype DX, you have 16 cancer genes with 5 controls, while the mama print is more extensive with 70 cancer genes being examination. So these are special techniques different from immunohistochemistry. So your Oncotype DX will use a quantitative PCR method, reverse transcriptase, and while mama print are micro. In this case, we have 70 test methods that are being used specific for cancer genes that you so yung variable both will do prognostication results in both in this case after doing your regular immunohistochemistry, the eligible patients that can undergo Oncotype or mama print examinations are the following. For Oncotype DX, you have an ER positive, HER2, T1 or T2 tumor with 0 to 3 nodes, while your mama print will require breast cancer patients which are in stage 1 and stage 2. So you have random scoring in this in Oncotype DX, which will predict the probable metastasis. If your score is less than 18, the risk for metastasis is low. While if you have a score greater than 30, the probable chance of metastasis is very high. So your mama print in the examination will give you good risk and poor risk intrinsic subtype. So these are the American Society of Clinical Oncologists recommends these examinations for certain cases of breast cancer. So as discussed, your Oncotype DX is a 21 gene assay used to predict the benefit from chemotherapy and to assess the risk of distant breast cancer recurrence. It is recommended for use in hormone receptor positive, HER2 negative, and node negative early stage breast cancers. So mama print is an examination that helps predict the chance of metastasis for some breast cancers at high clinical risk of recurrence based on estrogen receptor status, HER2 status, as well as tumor grade, lymph node status, and tumor size. So mama print can be used for breast cancers at high clinical risk based on, as was discussed, and that will follow this requirements or criteria. The tumor size should be not larger than 5 centimeters, or if larger, it can be removed with surgery. If you have a estrogen receptor positive, if you have a HER2 negative, and you have a lymph node negative or lymph node positive axillary node, but is only less than three axillary nodes. So we are proud to have this machine in our institution. We have the Ventana benchmark machine, an automated machine that will do all immunohistochemistry studies. So we do scoring techniques for your ER and PR as well as your HER2. So we score the positivity of the cells using the all-red scoring system, wherein specific proportion of the tumor as well as the intensity of staining is done to do an intensity or to do a grade. The HER2 positivity as required by ASCO CAP guidelines will follow this table, and we report only positive HER2 if you have a +3 intensity score. The plus 2 intensity score of HER2/neu will require another methodology for confirmation, your fluorescence immunohistochemistry, in situ hybridization techniques. So I think that's the end of my lecture.
Thank you, Dr. Cruz, for that extensive discussion on molecular profiling. Let us now proceed with our next lecture. Dr. Annalyn Ong Cornell, or Dr. Jinjin Cornell, is also known to everyone. Dr. Cornell graduated from UERM and recently finished her masterals in Barcelona, Spain. Masters on Health Economics and Pharmacoeconomics. Currently, Dr. is the director of the Cancer and Infusion Center here at our institution. She is also the assistant section chief of the section of oncology, Department of Medicine, Veterans Memorial Medical Center, Quezon City. She is the chairperson of the Institutional Review Board, also of veterans, clinical investigator in various phase 3 medical oncology clinical trials. She is an active consultant both in Perpetual Health Medical Center as well as Veterans Memorial Medical Center. Without further ado, let us welcome Dr. Ong Cornell.
Thank you, Tim, for that generous introduction. May I just share my slides? Okay. So, it goes without saying that without surgery and diagnostics and pathology, the options for treatment for breast CA cannot be defined. Just like technology and science and the cell phones that we use, improvements have really improved by big gains, by jumps, by leaps. A couple of years ago, probably a decade or so, everybody thought that all types of breast cancer would need chemotherapy to really come out with a cure. However, in terms of trying to tailor treatment options, and as Dr. Chito Cruz has extensively discussed earlier, not every breast cancer needs chemotherapy. So for the next few minutes, I'd just like to share which type of breast cancers can do away with chemo and will definitely benefit with endocrine treatment. We have to understand that breast cancer is a complex and diverse disease. It's not a one-size-fits-all approach to treatment. And not all cases require chemo due to advances in personalized medicine. And our decision for systemic treatment options in terms of personalized medicine rely heavily on the output of our pathology friends. So in our country, you will note that breast cancer really imposes a big social health economic problems because of the burden of disease that breast cancer has. For females, it's number one in terms of cancer sites. For both sexes, both male and female combined, it still has a big impact on our health situation. So breast cancer for our students is or can be recognized as swelling or density in the breast, frequently asymptomatic. It could present as a modification in the mammaries, glands, dimensions, configurations, or outward aspect. It could present as skin changes, dimpling, redness, or pitting. It could be a modification in the physical aspect of the nipple or areolar tissue, or it could be as simple as unusual or bloody discharge from the nipple. So these are just some examples of skin changes in breast cancer and some examples of nipple changes in breast cancer. For a clinician, we actually see breast cancer classified as invasive lobular carcinoma, and these are cancer cells which form in the milk-forming glands of the breast. Another clinical presentation that we see is invasive ductal carcinoma, and this is the most common type of breast cancer, which starts to begin in the milk ducts and spreads to other types or parts of the body. Next, we have our earlier stage or ductal carcinoma in situ. This is found in the lining of breast ducts. And you have our lobular carcinoma in situ, which is found in the milk glands or lobules in the breast. So, we'd always want to emphasize that the approach is not a one-size-fits-all. It is a heterogeneous disease, and the classification of subtypes have evolved through the years. Importantly, and one of the most widely accepted classification is from an immunohistochemical perspective. So, as the previous lecture I've mentioned earlier, your IHC perspective is actually based on the expression of the following hormone receptors: your estrogen receptor, your progesterone receptor, and your human epidermal growth factor receptor. And the combination of this type of IHC will come up with the 4 subtypes that are widely recognized: your luminal A, luminal B, HER2 positive, and triple negative. I got this slide from Dr. Chito Cruz because it really does segue to how we come up with decision treatments for our patients. So, for us medical oncologists, and I'm sure also my friends in surgery and radiation, we do try to identify and discuss with the patient the different types of subtypes our patient has: luminal A, luminal B, HER2, basal, and normal-like. So for receptors in breast cancer, what is important, especially for subclassifications, is that number one, we look at the estrogen and progesterone receptor. The estrogen receptor is a very important diagnostic determinant. It occurs around 70 to 75% of invasive carcinomas. Progesterone receptor is regulated by the estrogen receptor, and both the presence of your estrogen receptor and your progesterone receptor are expressed in breast cancers and can serve both as diagnostic and prognostic biomarker. It can predict for behavior, it can predict for responses to treatment. The higher expression of your progesterone receptor is associated with overall survival, time to recurrence, and time to treatment failure or progression. However, lower PR levels or progesterone receptor levels are associated with aggressive course of disease, poorer recurrence, and prognosis. The HER2 new expression is a human epidermal growth factor, and it occurs to as high as around 25% of breast cancers that we encounter in the clinic. It is very relevant in terms of choice of treatment, and overexpression is actually one of the earliest events during breast carcinogenesis. An amplification in your HER2 results to an overactivation of the proto-oncogenic signaling pathways, resulting to uncontrolled cell growth. And this, the presence of HER2 new expression plus 3, corresponds to worse clinical outcomes, and it also correlates with a significantly shorter disease-free period. Another important marker that we also take into consideration as clinicians is your Ki67. This marks cellular proliferation and provides information on how fast a tumor might grow. The higher the Ki67, the more it reflects the aggressive nature of the cancer, along with the response to treatment and time to recurrence. So, aside from your ER, PR, and HER2 new, your Ki67 is also important or crucial in choosing appropriate treatment therapy and possible follow-ups for recurrence. So, high expression reflects lower survival rates. So, the need for molecular classification to categorize patients who may benefit from targeted therapy, hormone therapy, and anti-HER2 therapy is very important for us doctors to give systemic treatments for patients with breast cancer. So just to go back, from a clinical point of view, luminal A, this is the type of breast cancer which in estrogen receptor is a very important diagnostic determinant. It is characterized by significantly high ER expression as opposed to the other subtypes versus luminal B, HER2 enriched, or triple negative. Triple negative is a subtype of breast cancer wherein there is a lack of expression of any of the above receptors. So the question comes up, when is chemotherapy really necessary? Traditionally, it has been known that the larger the tumor, the higher the stage, the higher the tumor grade, because it's more rapid in growth, these patients will require chemotherapy. Nowadays, we use the receptor status like hormone receptor positive cancers. We do realize that not all the time do they need chemotherapy. And the presence of very high expression of your ER and PR will really tell us that we need to reduce the need for chemotherapy for this type of patients. So before going on to patients who don't need chemo, who are the patients who need chemo? For luminal B, and this occurs in 10 to 20% of our tumors, it is higher grade and worse prognosis than luminal A. You might have an ER positive and a PR negative patient, but with a high expression of Ki67, more than 20%, then you know hormonal treatment alone will not suffice. It might benefit from hormonal treatment, but it has to be done along with chemotherapy. So usually this type of luminal B patients, they might be positive for ER and PR tumors, but their Ki67 will be higher and endocrine treatment alone will not suffice. This type of tumors have the worst prognosis, and yes, they do benefit from hormone therapy and chemotherapy compared to that of the other variant, your luminal A. HER2 positive group is an aggressive and fast-growing subgroup of breast cancer. They grow faster than luminal ones. For the past 20 or 30 years, your prognosis have improved with the introduction of very specific targeting for this HER2 positive group of breast cancer patients, and they do have a high response for chemotherapy. We need specific drugs against HER2 new breast cancer in the form of trastuzumab combined with other medications, pertuzumab, tyrosine kinase inhibitor, plus of course surgery and treatment with chemotherapy. For this type of patients, visceral metastasis is very common. Bone localization is also a common source of dissemination. Then you have your triple negative breast cancer who don't have any markers for ER, no PR, and no HER2 new. This is usually common for women under 40 years of age, and unfortunately this presents aggressive behavior. And these are the type of breast cancer patients who might present with BRCA1 and BRCA2. They present as aggressive breast cancer, they relapse early, they have a greater tendency to present in advanced stages. This type of breast cancer will definitely respond to chemo. Now, luminal A is the type of breast cancer that, chemo doesn't necessarily play a big role. You have a high expression of PR, you might have the absence of PR or HER2 new, and your Ki67 might be low. So clinically, our patients will present as low grade, very slow growing. They have the best prognosis with less incidence of relapse and higher survival rate. They have high response rate, or they have very good responses to hormone therapy like tamoxifen or aromatase inhibitors with limited benefits to chemo. So there are instances wherein chemo might not really play a big role for luminal A types of breast cancer. They relapse more at the bone level. They have lower rates of spread or metastasis to the visceral area in their CNS. The European Society of Medical Oncology recommend additional tests for this type of breast cancer. They use genetic platforms to establish which patients would benefit from adjuvant chemo only if needed, based on the risk of relapse and survival rate. So to summarize, what we're looking at really are patients with luminal A. You have a high ERPR expression, you have a negative HER2 new, and you have a low proliferative rate in the form of a low Ki67. These are times wherein chemotherapy is not the first option. So it's very important to know the subtype of breast cancer so that we can establish the best treatment option. And we know that compared to how breast cancer was viewed probably 30 or 40 years ago, gene expression studies have shown that breast cancer is very heterogeneous, and this heterogeneity has a molecular basis. Hence, the earlier lecture of Dr. Cruz discussing a lot of the molecular basis for treatment response, for treatment prognostication for patients with breast cancer. So, to highlight luminal A, what we really give for this type of patients is hormone therapy because they do respond beautifully to shutting off the sources of estrogen and progesterone in our patients. So, This occurs 70% of all cases worldwide. We really have to individualize our treatment based on tumor stage, biology, menopausal status. They are very responsive to endocrine therapy. Targeted therapy, if the mutant gene is present, is a very good option. Sometimes, but not always, chemo might help. So, adjuvant endocrine therapy or hormonal therapy for the lay people is universal for patients with hormone receptor positive invasive breast cancer of any stage and HER2 status. It reduces the risk of local regional recurrence, distant mets, and contralateral breast cancer while importantly improving overall survival. So this is the guidelines that we follow for adjuvant endocrine treatment in hormone receptor breast cancers or early breast cancer. So first we have to look at whether they are postmenopausal. And if the patient has no negative disease or 1 to 3 positive nodes but low risk genomic signature or low risk biology, then if you add chemo, it does not further reduce recurrence rates compared to endocrine treatment alone. So these are the patients that we don't need to give chemotherapy anymore. So we can give tamoxifen followed by your AI or aromatase inhibitors followed by tamoxifen. So these medications are endocrine treatment, and this type of subset of patients do not benefit anymore from chemotherapy. On the other end of the other side of the slide, you will look at the premenopausal patients. So for premenopausal patients with node-negative disease or 1 to 3 positive nodes and low-risk genomic structures or signatures, then adjuvant chemo did not reduce recurrence rates compared to endocrine treatment alone. So even premenopausal patients might not need chemotherapy. And these are your luminal A-like stage 1 patients. For patients who have luminal A-like stage 2 to 3 or luminal B-like stage 1 to 3, then OFS, tamoxifen or OFS plus aromatase inhibitor might be an option. So, for systemic treatment of hormone receptor positive HER2 new negative early breast cancer, we look at anatomic risk variables, but they do not influence the treatment sensitivity or benefit from adjuvant treatment. But if you do guide therapy selection, they can have a big impact on absolute risk reduction. So for higher risk hormone receptor positive tumors, aromatase inhibitor based therapy is needed. If we would want to consider chemo or targeted treatment or extended adjuvant endocrine therapy for postmenopausal women, ovarian function suppression and chemotherapy, then we need to check all of these factors in our patient. So what about targeted therapy for hormone receptor positive HER2 negative breast cancer? For stage 3 or high-risk stage, and ideally we do need to check for BRCA1 and BRCA2 testing, and this was mentioned in the earlier lecture. If our patient is BRCA1 into wild type or untested, then a cyclin-dependent kinase 4/6 inhibitor in addition to endocrine treatment will benefit the patient. So the addition of abemaciclib for 2 years reduced the absolute risk of recurrence at 4 years by 6.4%. And this is very important for patients who present with more than 4 involved lymph nodes or 1 to 3 positive nodes with either a tumor of more than 5 centimeters, a grade 3 histology, or a K167 expression of more than 20%. For targeted therapy with BRCA1 and 2 mutation and high-risk HER2 negative, for stage 3 or high-risk stage 2, then we can give adjuvant olaparib for 1 year plus endocrine therapy, and this improves your disease-free survival and overall survival irrespective of the hormone receptor status. At 4 years, the absolute differences in DFS or disease-free survival and distant disease-free survival are 7.3 and 7.4% respectively. So, hormone receptor positive and HER2 negative patients will definitely need surgery as initial treatment modality. For women with larger tumors or clinical nodal involvement, we may consider systemic therapy either in the form of chemo or endocrine treatment. Your chemo can be effective for surgical downstaging of this type of patients, but we must remember that it is uncommon to get complete disappearance or complete pathologic response for this type of patients. So adjuvant endocrine therapy is universal for patients with hormone receptor positive invasive breast cancer, and endocrine therapy reduces the risk of local regional recurrence, distant recurrence, contralateral breast cancer, and improving overall survival. How about biomarkers? How do we try to apply the biomarkers that Dr. Cruz mentioned earlier? So for women with early stage breast cancer, especially those who are HER2 negative and ER positive, you will note that we try to classify the patients either premenopausal or less than 50 years old, or postmenopausal or more than 50 years old. For premenopausal, node negative, then we try to use Oncotype DX. If you will note, Oncotype DX has a high quality of evidence and a very strong strength of recommendation. For postmenopausal women of more than 50 years old and there are no lymph nodes, then the option of Oncotype DX or MammaPrint, but MammaPrint has an intermediate quality of evidence with a strong strength of recommendation. For node-positive postmenopausal women with 1 to 3 nodes, then we do either Oncotype DX, MammaPrint, or KI67. So we apply the concepts lectured earlier in terms of Oncotype DX. For us clinicians, we use it to analyze the activity of group of genes related to breast cancer recurrence to help predict whether our treatment option of chemo will benefit the patient. So this is important if we get a low recurrence score, and this indicates that chemo is not needed and hormone therapy alone would be effective for this type of patients. On one end, for the MammaPrint test, the purpose is to evaluate the genetic makeup of the tumor to predict the risk of recurrence in early stage breast cancer. The importance of this test is that it uses estrogen receptor, HER2 negative breast cancer. It helps us decide whether chemo is necessary alongside endocrine therapy. So, to wrap it up, not all cases require chemo due to advances in personalized medicine. Why do these tests matter? Why is it important? Important in terms of treatment planning. The tests guide us whether hormone therapy alone will be effective or if chemo and other treatments are required. It tailors the response to treatment for personalized approach. Patients with hormone receptor positive tumors may benefit more from endocrine therapy, reducing the need for aggressive treatments like chemotherapy, sparing our patients from adverse events. Endocrine tests help us clinicians to tailor treatment plans. It helps us ensure that patients receive the most effective therapies with least toxicity. So thank you very much for the attention. I hope we have given you guys an idea of how we tailor our approach to patients with breast cancer. Dean?
Thank you, Dr. Dean, for the clear and thorough lecture and explanation. We now proceed to our grand finale, our last lecture for this morning. Our last, but definitely not the least, of our lecturers, Dr. Benedict Crisostomo. He graduated from the University of the Philippines and also had his clinical internship and residency training in radiation oncology at PGH. He is a diplomate of the Philippine Board of Radiology in radiation oncology and also a fellow of the Philippine College of Radiology. He had his clinical observership in radiation oncology at Cedars-Sinai Medical Center in Los Angeles, USA. He is currently the clinical director of POCC Manila Med Radiotherapy Unit, and also an active consultant in Bicol Regional Hospital and Medical Center, as well as the La Salle University Medical Center, and of course, here at our institution. Please welcome Dr. Benny Crisostomo.
Good day, everyone. I am Dr. Chrysostom of the Department of Radiation Oncology, and I am here to shed a light on what is hypofractionation in radiation therapy for breast cancer. I have no conflict of interest to disclose, and I am currently an active consultant of the hospital. Here is an outline of my presentation, which I have tailored for our colleagues, healthcare staff, and trainees in the audience. I will focus on these questions on hypofractionated radiation therapy and its role in the treatment of breast cancer, and we will go by these questions one by one. So firstly, what are the indications of radiation therapy for breast cancer? Radiation therapy is a form of treatment delivered using high-energy X-rays, to put it simply, focusing on control of disease while sparing at-risk normal organs and thus minimizing side effects. In our specialty of radiation oncology, this treatment is typically done through two means. One is externally, or EBRT, where radiotherapy is delivered typically using linear accelerators or LINACs, such as those available here in our institution, the IMRT-capable Varian Unique and VMAT-capable Halcyon machine seen on the left. Radiotherapy may also be delivered internally in our patients' bodies through brachytherapy, which is occasionally used in breast cancer through balloons and catheters seen on the right. For this presentation, we will mainly focus on external beam radiotherapy. In the latest data available from the WHO Global Cancer Observatory, or GloboCan, we can see that breast cancer comprises roughly a third of all new cancer cases in the Philippines, with an increase in incidence from 27,000 in 2020 on the left here on the pie chart, going up to 33,000 in 2022 on the right. Among radiotherapy centers, breast cancer is one of the most common referrals we receive for treatment as well. Indications for radiotherapy and RT dosing in breast cancer depends largely on stage, histopath, and other patient features. Depending on whether neoadjuvant chemotherapy was done, radiotherapy is typically administered adjuvantly after surgery to statistically reduce recurrence rates, whether through breast-conserving surgery as seen on eggshell slices of RT plans on the upper right here, or RT may also be delivered after mastectomy as in the second image. Radiotherapy may also be indicated for symptomatic or palliative treatment of metastasis, hemorrhage, among others, as seen with the bone metastasis patient on the third image, but we will focus mainly on adjuvant treatment for this presentation. In the latest version of the US NCCN guidelines for patients who underwent mastectomy with surgical axillary staging, radiotherapy is indicated or at least considered for most cases depending on histopath results, as shown in the red box on the right. The same is true especially with high-quality Category Level 1 evidence in the setting of lumpectomy or BCS, given the evidence on the reduction of ipsilateral breast tumor recurrences among patients who receive adjuvant whole breast RT. Discussion of these treatments are best done in a multidisciplinary setting with all specialties involved. Locally, we also have national CPGs for breast cancer available from DOH, where adjuvant RT is recommended for both post-BCS and post-MRM settings. So with this backgrounder, let us now focus on fractionation and the role of fewer RT fractions or hypofractionation in breast cancer. For my patients, I typically orient them on fractionation on how we prescribe RT dose depending on each patient case, and divide this dose into a number of days to reduce side effects, which is why RT sessions are called. Historically, increasing fraction number was found to reduce the severity of late side effects with the conventional radiotherapy techniques available at time plates on the right. However, with modern RT equipment, we are now able to safely deliver RT in as few as 1 to 5 fractions with stereotactic techniques that may be familiar for some in the audience. By definition, conventional fractionation is where we prescribe 1.8 to 2 gray per day, where a typical RT prescription for breast cancer consists of 25 fractions of 2 gray per day to a total dose of 50 gray. With hypofractionation, we lessen the number of fractions needed to achieve the total RT dose by delivering more than 2 gray, or the same as 200 centigrade per fraction. This is a visual representation of the difference in total treatment duration for hypofractionated RT regimens, where we can see the fraction size being vertically higher as we lessen the number of fractions, seen here in green in the moderate hypofractionated row, going as extreme as 5 fractions in red here for ultra hypofractionation, where the vertical bars are much longer. We will go back to this particular slide frequently later, as this shows the various hypofractionated regimens studied by different trials. Seen above in green are schedules by the START-A trial, where only 3 fractions are given per week with the same total 5-week duration as conventional. In the middle in blue are moderate hypofractionation schemes, which lasts 3 weeks instead of 5. And lastly, below in orange are ultra hypofractionation regimens, where only 5 fractions are given in as short as even a week only. For this slide, important to notice that the total dose on the right is lower as we decrease the treatment duration, such that 50 gray in 25 fractions does not become 50 gray when it's shortened to 15 fractions, and more so it's not equivalent to 50 gray in 5 fractions. So it goes down to as low as 26 gray in 5 fractions for the fast forward schedule. The decrease in total dose is explained by radiation biology, one of the disciplines within radiation oncology. Please bear with me just for this one slide, since this would explain our preference for hypofractionation for breast cancer. The key takeaway here is that the response of both normal and cancer cells to changing the daily RT dose is not linear, represented by this alpha-beta ratio coefficient. For other cancers, this ratio is much higher at 10 than normal cells, which range from 2 to 3. This difference allows us to increase fractions conventionally to lessen normal organ effects. However, experimentally, the alpha-beta value of breast cancer was found to be at 2.8, well within the range of the alpha-beta ratio of normal organs as well, quite similar. So the problem here is that hypofractionation may cause more normal organ side effects. But these are now prevented with the modern RT techniques that allow us techniques such as cardiac sparing currently. So this behavior of breast cancer cells theoretically rationalizes the comparison of radiobiologic equivalent RT prescriptions here seen below, such as 50 gray in 25 fractions, which is equivalent theoretically to 40 gray in 15 fractions, versus 28.5 gray in 5 weekly fractions, where trials compared efficacy and toxicity profiles, to be discussed later. So going back clinically, away from the theoreticals, we will now look into contemporary trials that establish the role of hypofractionation for breast cancer. We will first look into the patient characteristics or inclusion of these trials, on whether they included BCS and mastectomy patients or both. Going back to this schema slide, the trials in the red box, mainly the START, Canadian OCOG, and FAST trials, explored hypofractionation mainly in the setting of breast-conserving surgery or lumpectomy. We already have long-term evidence for hypofractionation, as the OCOG or Ontario Clinical Oncology Group trial was completed in Canada in 1996, published in 2001, which explored hypofractionated RT among post-lumpectomy patients with node-negative breast cancer. Studies on hypofractionation are also common in the United Kingdom with their nationalized health service, which standardized radiotherapy schedules to 3 weeks instead of 5 through the STAR trials from 1998 to 2002. It was in UK where also they further explored the safety and efficacy of a 1-week RT regimen in the FAST and FAST-FORWARD trials, which were completed in 2014. This table shows the characteristics of patients enrolled in these trials. It is important to note that most patients in these trials were treated with lumpectomy or breast-conserving surgery. However, it is quite known that the most common presentation of breast cancer in our country is locally advanced, necessitating mastectomy. Although there are certain percentages, less than 10% in the START A and B, and fast-forward trials that underwent mastectomy, seen here in the red boxes, we should also look into trials that investigated hypofractionation in the MRM setting. So far, there is one published trial from China which looked into a 3-week RT regimen, almost similar to the START and OCCULT trials, but in the post-mastectomy setting. This trial from Beijing by Wang was published in 2019, including so-called high-risk breast cancer patients who underwent mastectomy and compared hypofractionated versus conventionally fractionated radiotherapy. We also based the use of hypofractionation on the small percentages of subset of patients in the START and FAST-FORWARD trials. Other post-mastectomy trials, especially in the post-plastic reconstruction setting, are also ongoing, including the FABREC trial from the University of Utah and RT-CHARM trial from Boston, which are awaiting publication. We will now look into the efficacy of hypofractionation one by one through each of these trials. The Canadian OCCULT trial enrolled more than 1,200 post-BCS-only patients and looked into recurrence rates between the 5-week versus a 16-fraction 3-week regimen. This trial found similar ipsilateral breast recurrence rates, which continued with 10-year long-term data, as shown in the graph on the right at 12 years. The UK's trials for standardization of breast cancer radiotherapy, or START, Pilot A and B trials enrolled more than 2,000 mainly BCS patients, each with 10-year long-term data already, and found similar local regional relapse rates for the two arms as well. To discuss again, hypofractionation has also been classified into moderate as the START trials, typically 3-week regimens, as compared to the 1-week or 5-fraction ultra-hypofractionated regimens from the UK FAST and FAST-FORWARD trials, depicted down here in orange. The UK FAST trial first investigated the feasibility of a 5-fraction RT regimen only among BCS patients, but was first delivered once a week for 5 weeks and compared also to 5 weeks conventional. The subsequent fast-forward trial enrolled more than 4,000 patients, 6% post-mastectomy, and with an accelerated 5-day scheme delivered in only a week, and compared this to a 3-week regimen and found non-inferiority for local control. This was actually a 3-arm trial and found that a 1 gray increase was more toxic than moderate hypofractionation. The problem with ultra-hypofractionation is the underrepresentation of patients needing nodal RT to the axilla and supraclavicular regions, which are typically found in our patients locally. The ongoing R-HEAL and Hypo-RT trials enrolled N1 to N2 patients and are currently investigating the safety of the fast-forward regimen for local regional RT. In the post-mastectomy setting, the trial from Beijing by Wang enrolled purely post-MRM patients at 820 and found no difference in local regional recurrence rates with 15 fractions of RT at median follow-up of 5 years, shown here on the graph on the right. In the setting of plastic reconstruction post-mastectomy, there are concerns of adverse outcomes for adjuvant RT in general, let alone for doing hypofractionated techniques. So the RT-CHARM trial investigated using the Canadian OCCULT regimen for these patients and is currently awaiting full-text publication. Meanwhile, the FABREC study published in the Journal of the American Society for Radiation Oncology, or ASTRO, enrolled 400 patients with immediate reconstruction after MRM and also investigated the same OCCULT Canadian regimen, finding no difference in side effects with better quality of life for hypofractionation. For these next questions, some toxicity outcomes have already been discussed to be similar among the trials, but we will now delve into the specifics. For the START trials, toxicity outcomes were similar in terms of cosmetic breast shrinkage, brachial plexopathy, cardiac toxicity, and symptomatic lung fibrosis. Axillary lymphedema, which is a combined outcome of surgery and radiotherapy was found in more in the conventional arm, but not accounting for baseline edema pre-RT. Apologies again for the busy slide, but the left image shows similar cosmetic outcomes for the START and Canadian BCS trials, while on the right showed no significant difference in acute toxicity outcomes for the Chinese post-mastectomy trial in terms of dermatitis, pneumonitis, lymphedema, and heart disease. Another RT toxicity study was recently presented in the 2024 European Society for Medical Oncology ESMO Congress. The HYPO-G01 trial investigated 3-year incidence of arm lymphedema for a 3-week hypofractionated RT regimen. At a median follow-up of around 5 years, the hypofractionated RT arm was non-inferior, with 1/3 of patients having lymphedema in both arms. For the ultra-hypofractionated RT setting, on the left shows cosmetic and arm edema outcomes for 1-week versus 3-week regimens. Pertinent for our colleagues is the image on the right, which shows the timing of onset of skin toxicities for various regimens. In this graph, grade 2 acute toxicities are typically seen during our weekly on-treatment visits by patients during our usual 5-week conventional schedules. However, for 3-week regimens, incidence starts to peak from 3 to 5 weeks right after they complete or graduate from daily RT. Also important to note that for ultra-hypofractionation, toxicity in the skin also peaks the week right after completion of RT, then tapers off until the 4th week from RT initiation. It is also fortunate that we have local toxicity data for hypofractionated RT in the local setting. This is a single-arm phase 2 trial by my colleague and batchmate in residency training, published in 2022 and used the schedule by Wang. With a median follow-up of almost 2 years, 62% of patients had grade 2 dermatitis and 7% with grade 3 toxicity, all resolving after 3 months. With the evidence available as basis, let us now look into guidelines for hypofractionated RT. Both the American and European Societies for Radiation Oncology recommend hypofractionation for the vast majority of patients requiring adjuvant RT fitting these criteria. ESRO goes further in recommending 5 fractions as standard of care, also in light of socialized healthcare. For the UK and its NHS health system, hypofractionation is also much favored, with stronger language used in its consensus statements deeming it standard of care as well. For our national DOH CPGs, hypofractionated RT is preferred, particularly in the BCS setting. Aside from the local toxicity data from my training institution, we also have a commentary on the utilization of hypofractionation in the Philippines from a colleague from UST, published in the Journal of Astro. They narrated the hesitation of practitioners due to underrepresentation of the most common features of patient referrals we receive, such as those post-mastectomy and those requiring nodal RT. Another impediment identified is issues with health insurance, since reimbursement is fee-for-service per instance rather than by disease or case. And lastly, is hypofractionated RT for breast cancer available in our institution? Our IMRT-capable variant-unique LINAC and volumetric modulated art therapy or VMAT capable Halcyon machines are both capable of delivering hypofractionated radiotherapy for our patients if ever indicated. These IMRT and VMAT radiotherapy techniques, as well as available immobilization devices and some organ-sparing techniques, allow us to deliver very conformal treatments to minimize late toxicities to normal organs. I will entertain questions during the open forum. Thank you very much for your kind attention.
Thank you, Dr. Benny, for that comprehensive presentation on RT. We will now open the floor to some questions. In the interest of time, we will be entertaining just few questions. May I request all the speakers to turn on their cameras and microphones as well. Okay, to start the ball rolling, We'll start with the lecture of Dr. Bene since ito yung medyo fresh pa. Is there a difference on the onset of skin toxicity during RT between 3 weeks and 5 week schedule?
Hello, good morning. Do you hear me po?
Yes,
Hello.
yes. No.
Yes, po. For that question, for our 3 fraction schedule, hypofractionated versus the conventional yung 5 week na fractionation. Typically for our conventional fractionated regimens, yung 5 weeks, we experience, ako po, I typically orient our patients that the side effects in terms of the skin, the dermatitis, appears earliest at around 3 weeks. Sabi ko pa nga, pag nag-double digits na yung days nyo, like day 10 na, ganun po, 3 weeks dun sila sa start. So, yung important po dun is, during follow-ups, we can catch it early on and until matapos yung radiation therapy sessions nila, na optimize pa namin sila, we can give emollients, steroid creams if needed, or flamazine, or even dressings depending on the patient's response. However, yung important po for hypofractionated regimens is the onset of there was a slide earlier there, the onset of skin toxicity is quite relatively early, and it might happen even after na matapos yung radiotherapy center session. So kunwari yung 3 weeks, yung 15 fractions, the skin toxicity might appear right before they graduate or after. So the important part for that is they need to still come with us for follow-ups the week after, and especially when they come back with our co-managing specialties and oncologists to catch these if ever po that if they appear right after, no, para na babantayan pa rin namin. For the 5 fraction regimen, yung 1 week lang dun sa graph, nag-peak yung incidence ng dermatitis the week after sila mag-finish yung second week after completion of radiotherapy. So, I guess that's the important thing to note there. Yung onset is quite different among the regimens. Thank you po.
Is very important. For Dr. Pao, you mentioned earlier and explained regarding the anatomic and physiologic screening. What is your comment? Of course, you have mentioned that mammography is of the gold standard. But what is your comment on utilizing MRI and ultrasound for breast screening as well? Is it just an adjunct, or can it has to be both, or can you do just the MRI and ultrasound?
Yeah, thank you for that question, Dr. So, you're correct. MRI and ultrasound remains to be adjuncts or supplemental studies for breast cancer screening. So again, mammography remains to be the gold standard. So, I actually get a lot of patients in the clinical setting constantly asking me if they can just do the ultrasound because mammogram is painful. So what I tell them is that we can really miss something on ultrasound, especially if we're trying to catch the early forms of cancer, which can only be seen as microcalcifications and can only be detected by mammography. So for me personally, I think what has a lot of potential here is actually contrast enhanced mammography. So because in contrast enhanced mammography, we do get images similar or comparable to that of digital mammography to evaluate the calcifications. And additionally, we get the vascular-based aspect of the imaging.
Thank you, Dr. Carl. I think our next question will be addressed to both Dr. Jen and Dr. Jean. Regarding HER2-enhanced breast cancer patients for whom PCR rate is almost 75%. So how do we monitor response, and what are the options for surgery after, or what are the other options? Dr. Jen maybe can answer first.
We see the patients regularly while they are undergoing the neoadjuvant chemotherapy care of our medical oncology friend. It depends on you whether you want to see the patient every other cycle or after every cycle to detect whether the tumor is indeed decreasing in size and whether the patient is tolerating the chemotherapy to decide whether we can complete the regimen and do the surgery after. Now, before the neoadjuvant chemotherapy is started and on follow-up, we ask the patient to think about what kind of surgery she would want if the tumor decreases in size significantly. Now, besides the other factors that you have to consider, such as genetic testing, wherein you do not have any choice but mastectomy. Pending that, then you can ask the patient, would you want to have mastectomy or partial mastectomy? If it's mastectomy, then you do not really have to run after the tumor, whether it disappears or not. But if your patient would decide to have partial mastectomy after and the size of the tumor significantly decreases in size to the point that it is barely palpable, then that is, I think, the best time for you to discuss putting in the possibility of putting in a hydromark or a metal marker, ultrasound guided, into the tumor so that your to guide your partial mastectomy after the neoadjuvant chemo.
Yeah, to take off from what Jen mentioned, this is actually the beauty of working together with other specialties. We get to get the outcome that we need from our patients. At the same time, we also get their opinion as to what type of breast surgery they are amenable with. For HER2 positive tumors, we usually do chemo before surgery because the response after completion of the systemic treatment, especially if it's a complete pathologic response wherein the tumor is not visible anymore after surgery, also translates to a better overall survival. So giving chemo prior to surgery not only helps with getting better treatment outcomes from a surgery point of view, but it also helps us prognosticate in terms of how aggressive or not aggressive our patient will be for the next few years. Tin?
I guess, Dr. Regine, did I cut you? No?
Yeah, that's okay. Yeah.
For Dr. Regine, can all cancer patients receive tamoxifen as part of the hormonal treatment?
Tamoxifen has been present since forever. It's actually a very effective treatment for breast cancer. It's just that for postmenopausal women, there are newer drugs which are safer in terms of adverse events. Usually for elderly patients, one of the side effects of tamoxifen that you'd want to do without is blood clots. So yes, it is possible to give it for elderly patients, but since there's a better drug for elderly patients, we will prefer aromatase inhibitors instead of tamoxifen for postmenopausal women.
Thank you, Dr. And I think we're nearly at the end. We'll be entertaining the last question. For Dr. Chito, Doc, should molecular profiling be routinely included in diagnosed cases of breast cancer patients?
It's imperative that these three or the regular the two hormonal receptor status as well as your HER2 together with your proliferation index marker be included as a routine procedure in diagnosed cases of breast cancer, as was discussed by Dr. Jinjin. The prognostication as well as the risk for metastasis as well as the chances of it relapsing is being determined with the use of this proliferation as well as hormonal status receptor assays. So I guess whenever a patient is diagnosed to have breast cancer, the four markers should be included in the examinations done for the patient for better prognostication as well as determination of treatment protocols in the different subtypes of breast cancers as was discussed.
Thank you, Doctor. Do we have any other questions? I think I don't see any other question in the chat box. So with that, we will close the open forum and proceed with the awarding of certificates. The certificate of appreciation will be given to our beloved and our well-esteemed speakers. And the citation is as follows. In sincere acknowledgement of your valuable contribution as resource speaker during the Breast Cancer Awareness Month activity, given this 26th day of October 2024 at the Tamay Tower Perpetual Health Medical Center, Las Piñas City, or virtually here in Zoom. Signed by the Hospital Director, Ma'am Christina Consing, the Executive Medical Director, Dr. Adrian Kidlat, and of course, our President, Sir Richard Tamayo. Yes. Thank you.
May photo ba tayo? Sabay-sabay?
Yes, Doc, meron po. I think we will do it after the closing remarks or we'll do it now? Dr. Regine, we'll do it now po. Okay, sige po. So, we will request all our speakers and our participants to turn on their cameras for the photo op. Dr. Jeco, you'll be the one to take the picture, right?
Yes po, Doc, we'll take the photo.
We acknowledge the presence of Dr. Nadal and Dr. Largado. Thank you po.
Thank you. Thank you.
And of course, our other esteemed consultants, Dr. Magbogo, Dr. Iya Reyes, Dr. Jen Conde, I think I saw also.
Doc will be taking the photo na po. So everyone po, ready? Na count of 3. 1, 2, 3. Smile, everyone. Okay po, one more. 1, 2, 3. Smile. Okay na po. Thank you po, doctors.
Okay. We will have the closing remarks to be given by our Executive Medical Director, Dr. Brigadier General Adrian Kidlat.
A warm good afternoon to everyone. As we bring today's Breast Cancer Awareness celebration with the theme, I Will Survive, Survivorship Issues After Breast Cancer, to a close, I want to thank each of you, survivors, loved ones, and healthcare providers for being a part of this meaningful event. Today, we honor the courage and resilience of all who have faced breast cancer and celebrate the strength it takes not only to survive but to thrive beyond the diagnosis. Let us carry forward the hope, strength, and knowledge gained here as we support those navigating life after breast cancer. To all survivors and their loved ones, you inspire us every day, and we are honored to stand with you. Thank you once again to everyone involved in organizing this event. Have a wonderful afternoon, and may we continue to live in strength and in hope. God bless us all.
Thank you, Dr. Kidlat. We would like to thank our sponsors for this morning's event. We also have another event later this afternoon on site. Okay. And also, This is a prelude to another MDT activity on January 2025 on hepatobiliary malignancies. So see you po on January 2025. Kindly scan the QR code posted on the screen for the evaluation form. I think Dr. Jeco, you will also post it on the chat box, the link, or just scan the QR code. We will just scan. Okay, kindly scan the QR code for the evaluation form. Thank you very much. Yes, Dr. Jen Mercado. Yes, you're raising your hand.
Oh, thank you also to Jeco and the marketing team. And you, Dr. Polido, thank you also.
Thank you. Thank you po. Thank you everyone for this morning, very fruitful morning activity. So I think okay na po. We'll call it a day, a dare. So the evaluation forms, the link for the evaluation forms are posted on the chat box. Thank you very much. Oh, Dr. Lopez is also here in the audience. Good morning po, Doc. We also have other consultants, especially, syempre bias, from IRAS. Dr. Kaukom, Dr. Lodronia, I think I saw also in the audience. Are there other consultants?
Recording
po?
stopped.
Dr. Magbo is here.
Yes, mentioned Dr. Magbo. And also later this afternoon, si Dr. Okay po, I think, yeah, that's it po. Thank you very much po for gracing this event virtually. Thank you po. So, see you po on January 2025 for hepatobiliary. Thank you po.
Bye. Thank
Oh shit.